a transitional care coordinator, and my goal is to follow patients to prevent readmissions. My focus is always making the patient the priority and making sure the care is not just in the hospital, but once they leave the hospital doors, that their care is taken care of once they continue throughout their medical needs. I try to interview them in the hospital. Once they're identified, I'll go to the hospital room, explain my program, explain that I will be following them after they leave the hospital. And some of them are kind of, really? They're not quite sure. I have one individual that's 32 years old, been to the hospital 70 plus times in the last couple of years.
There was a lot of factors like no transportation, no job, unstable financially, and it was very hard for him to keep his medical appointments. So I actually was just working with Rob to assist the patient on anything possible.
I was going through a little bit of a rough time with losing my mother and grandmother within a year apart. So I just, like a lot of things I didn't really stop caring about. Like for instance, my health issue. You know, it really didn't matter, so I started doing a whole bunch of stupid stuff that I shouldn't have been doing.
And so I really wanted to concentrate on this gentleman to see if there's a root cause that we can fix on this individual.
Robbie came into the picture and started helping me out. You know, staying out of the hospital, making sure all my appointments are correct.
I paired up with Variety Care to go through his medications and his treatments. I interviewed the individual in the room. A lot of it was his medication non-compliance, and he couldn't afford the medications.
I think it was just, this was a patient that did not have a primary care provider, and because of our relationship with Integris Southwest, it was just kind of a natural process for them to refer him to us. This case, you know, controlling his chronic lung disease, again, we thought we were prescribing drugs that would have done it if he was taking them, but he was not. And there's a myriad of reasons why people are not taking their drugs. Many times it will be cost. You know, we write the drugs, but we never take the time to ask them, can you afford to fill this? If they're insured, that's one thing, but even if they have a fairly high copay, if they're insured, they may not get it filled, or they may take it intermittently because it makes the drug last longer.
One of the biggest barriers I have is finding resources for the individual, especially when it comes to medications. There are pharmaceutical assistant programs out there, but getting that information out there, do they qualify? Do they even have transportation to get the medications? Can you get the prescriptions written? Are the prescriptions written in the hospital that they can have them filled before they get home on a Friday afternoon? Can I get a hold of the primary caregiver? So really just concentrating on the patient before they leave. Can I get those prescriptions? Do they have a 3, 4, or 5 day supply before they get to the primary care physician? And if they don't have a primary care physician, can I use the resources to have them find one? And really just concentrating on that patient once they're ready to leave the hospital.
He's been there a lot. You know, like beyond what I think he's supposed to be doing sometimes.
Once I got him established on the routine, it's like, okay, what can you do to help yourself? How can we get you to get these medications and all that? So I stabilize them and then educate them, teach them to take care of themselves.
He knows now how to take care of himself, and if he has any trouble getting his medication or getting an appointment here, he knows that he can call at any time and let us know, or let me know, and I will help him.
Since then, this individual's lost probably about 80 pounds, not wearing his oxygen as much. The readmissions have gone down. Compliance with medications up. He's seeing physicians on a regular basis. So it's really, even though it's taken about 8 months, it's just taking that extra time, that other extra care in this patient.
The last gathering that I got with my family, I think it was Easter, and they were all wondering where I've been. You know, and I really didn't realize until then how much family, really much mattered. Because it's like they missed me so much. So it just made me want to, like, you know, try harder, you know? So, like, you know, that's what I did. I tried a lot harder. You know, my blood pressure's down, my diabetes is down, way down. I just feel like I'm getting better every day.
He may relapse, but don't give up on him once they relapse. You always care.
Not giving up is critical to this population because there are going to be many reasons, many problems. You know, when you're dealing with people again that are underserved or uninsured, they're going to have many, you know, social and economic challenges that are going to prevent them from being as, you know, compliant with their medication regimens as we would like to. And you can get frustrated with that, and you can just want to say, well, I don't have time to deal with this. But I think that's the challenge that we have as a healthcare community, is that we have got to start thinking differently about patients. And within the context of the patient-centered medical home philosophy is that the organization assumes responsibility for figuring out these things and helping patients get what they need, even when it's difficult.
You know, I went from the bottom, I'm halfway there, you know, so there's some kind of progress. I'm not going to say I'm 100% because I'm not, but I mean, I'm getting there, you know. And with his help, I'm going to probably end up being there all the way.
When I first came into nursing, I took the oath to love the sick. And it doesn't matter if they're non-compliant, compliant, rich, poor. I just want to help people.